Hi, good afternoon. My name is William Roller. I'm a registered nurse. I'm also a certified emergency nurse. And today we are going to discuss triage in the emergency department. There are so many factors when you're triaging a patient in the emergency room that come into play. Picture it. It's Monday morning in the ED. You just so happen to walk through the emergency entrance, which is bad luck if you do that. You got 20 rescues lined up. You got 40 in the waiting room. How do we sort the patients? How do we get them going where they need to go so they can get care in a timely manner, right? It's called triage. Triage is French for the word sort. And in the emergency room, we do not sort by order of arrival. Rather, we sort by severity of illness of the patient. So your sickest patient's going to go back first. Your patient in distress is going to go back first. Your chest pain is going to go back before your finger laceration. Just throwing some examples here. However, most emergency rooms, use a 5-point scale known as the Emergency Severity Index. We know this as the ESI. The ESI was created in conjunction with the ENA, the Emergency Nurses Association, back in the late 90s to sort of streamline and systemize and keep it across the board the way we triage our patients. Most EDs I worked in EDs for 7 years. 2 of those years I've been a nurse. We've used Emergency Severity Index. So it's quite common. And the Emergency Severity Index uses 3 decision points. These decision points determine the level of triage based on acuity. Your level 1s are your top priority, and your level 5 is your less priority. And we use 3 decision points to determine the patient's triage or acuity level, and that determines what patients are going to go back before which patients. So, the 4 decision points include: does the patient require life-saving interventions? First off, let's define a life-saving intervention. CPR, emergent intubation, emergent access to blood, massive transfusion protocol, any trauma activation, any delivery of a baby, that sort of stuff would be your ESI of level 1s. Your cardiac arrest, your code blues, your stroke alerts that wind up getting emergently intubated, your overdose that was thrown out of a car, who's unresponsive and have apneic respirations. Those are your patients that are requiring a life-saving interventions. If they do not present with a life-saving intervention need, is this a high-risk situation? Is the patient in severe pain or distress? Is the patient confused, lethargic, or altered? Let's define a high-risk situation. You're elderly with chest pain. You're suicidal, homicidal, and they're actively doing it. Either you have to treat your patients as suicidal, homicidal, if they're expressing it. No matter if they're just here, I just want a turkey sandwich, but I want to kill myself. These patients need to be seen before anyone else, because if they're in that waiting room, they cannot wait in that waiting room longer, because then they'll intent. They will act on their intentions. Any patient with abdominal pain, not abdominal pain, but depending on what it is. If it's like a ruptured ovarian abscess or they're hypovolemic, they have danger vital signs, then they'd be a level 2. Your ETOH with head injury, these patients are brain bleeds until proven otherwise. Your altered mental statuses, if they're protecting their airway, they're level 2. Your ETOH patients, as I mentioned, also your immunocompromised patients. That come in with fever. Any infant less than 28 days old coming in with fever, automatic ESI of 2, emergent. And if none of these persist, then we're going to examine how many resources will the patient require. Let's talk about resources for a second. Resources are your labs, your x-ray, your EKG, your CT scans, your IV, IM, and nebulized meds. Any simple procedure will be one resource. Any complex procedure is two resources. So let's say you have a patient who needs a lab and an EKG. They're automatically a level 3 based on this. Not resources are your point-of-care testing, like your glucose and your HCGs. RD consults is also considered a resource. However, consults with the PCP are not considered a resource. Your history and physical, including pelvic. Yes, it's a resource that requires a nurse. However, it's part of the medical screening exam. And we're going to talk more about EMTALA as well. And again, like your constant sedations are level 1s. Your simple wound care is not a resource. If you're dispensing a sling, crutches, or splints, those are not considered a resource. However, any complex procedure is counting as two resources. And according to this ESI algorithm, if a patient requires no resources, as defined by Emergency Severity Index, they're at ESI level 5. They're your non-urgent patients. If they require one resource, like a UA, or one medication. However, if it's a PO med or a tetanus shot, that does not count as a resource. And if they require 2 or more resources, automatically level 3. These are your abdominal pains, for example. However, if the patient requires many resources and they have what is known as danger vital signs, according to Emergency Severity Index, you might want to think level 2. There's also another important special consideration when assigning ESI level. This is known as your pediatric assessment triangle. I do have a video on this separately, but it determines your sick versus sicker versus sickest. For the sake of any TNCC, CEN, or Certified Emergency Nurse Exam, or your Certified Pediatric Emergency Nurse Exam, patient, there's no such thing as non-sick. That's not an option. So you're given your sick versus sicker versus sickest. So there's sick versus non-sick is actually sick versus sicker versus sickest. You have, if there's no alterations, they're sick. Sick till proven otherwise. Let the workup reveal it. 1 alteration is sicker. 2 or more alteration is your sickest patient. You want to bring them back. And in the pediatric world, your assessment triangle is based on your appearance and airway, your work of breathing, and your circulation. All right. So we're going to do a couple scenarios, but then I'm going to come back in and we're going to discuss EMTALA as well as when a mass casualty occurs in the emergency department. I also wanted to delve in a little bit more before I go into the ESI videos of 2 more high-risk situations. Your ESI of 2s, right? Your needle stick. Even though they're asymptomatic, this is a life-changing event that could occur from the light stick. So this is a high-priority urgency. This has full sense of urgencies as well. Your needle sticks are ESIs of 2s. Your stroke alerts are also your ESI of 2s. Anyone who has symptoms of a stroke are ESI of 2s. Your STEMIs are also could be ESI 2 or 1, depending upon the patient's status. So I just wanted to cycle back to that. Any respiratory distress can be at level 2 as well. I just wanted to double back on that before we get into the ESI examples as well, because you're going to see a couple level 2s in your examples.
Okay, now we have a case. You're notified by EMS that you're receiving a 78-year-old male who collapsed in the garden. His daughter called 911 and immediately started CPR. He was defibrillated 3 times in the field, and he was brought into the emergency department in sinus bradycardia, and his pressure was 88 systolic. So what do you want to do with this gentleman?
ESI level 1. He's post-arrest and will require continuation of the resuscitation. He's also going to be going on a vent and will need drugs.
Absolutely. He's still hypotensive, he's bradycardic, and he's going to need some IV vasopressors, probably dopamine. He may deteriorate back into VFib for all we know, so he is definitely a level 1, and there is really not much more to say about that.
Let's do the next case. A 14-year-old male is brought to the emergency department by his mother, who tells you she is concerned her son has poison ivy. He was doing some yard work for a neighbor and 2 days later developed itching, redness, and little blisters on his arms. She is concerned that he will spread it to the whole family. He's healthy, takes no medications, has normal vital signs. Okay, do you think he meets level 1 or level 2 criteria?
No way. They need to go home. They should have gone to see their doctor.
Okay, so maybe home after some great patient education. So are you saying this patient is not going to require any resources?
Right. He is an ESI level 5. He's going to be instructed to go home to get some over-the-counter medicine.
That's right. Don't forget, this is a really good opportunity for patient education.
Okay, we're going to do something a little bit different. We're going to actually watch a patient scenario here and then kind of talk about it as a group. Sound like a plan? See if I can turn on this video. These are some videos of some patient scenarios that are actual real scenarios here.
Linda Brooks? That's me.
Have a seat, Linda. My name's Nikki. I'm one of the nurses. I need to ask you a few questions about what brought you here today. You're having some belly pain and bleeding?
Yeah, it's not really pain. It's like cramping up on me, like I have my period. I thought maybe I was pregnant because I skipped a period.
Okay. How long have you had this cramping?
It started about 2 hours ago. I was sitting watching TV and it just came on, kind of sudden.
Okay, on a scale of 0 to 10, with 10 being the worst pain you can imagine, how do you rate this cramping?
About a 5.
All right, and you're bleeding?
It started spotting in the morning, and now it's like a heavy period.
Have you passed any clots?
No.
When was your last normal menstrual period?
It's been a while. Let me see. Maybe 7 or 8 weeks ago.
Have you ever been pregnant?
No.
Okay. Any dizziness?
No.
Okay, good. How old are you?
23.
Any medical problems you see a doctor regularly for?
No, I'm real healthy.
All right, do you take any medications?
Nope.
Any allergies to any medications?
No.
All right. I just need to take your blood pressure and put this thing on your finger.
Lower abdominal pain with vaginal bleeding is a common chief complaint in women of childbearing age. The cause can range from an ectopic pregnancy to a spontaneous abortion to an irregular menses. In order to decide the acuity level, it is important to look at the patient. This healthy 23-year-old female does not require immediate life-saving interventions, so she does not meet criteria for ESI level 1. The question becomes, does she meet criteria for ESI level 2? And the answer is no. She is awake, alert, oriented. Her pain is 5/10, and her abdominal cramping is generalized, lower abdominal pain. Her skin is warm and dry, and she has experienced no dizziness, no indication that she has an ectopic pregnancy. The triage nurse feels comfortable that she is stable to wait in the waiting room. So moving on to resources. This patient will consume a number of resources. She will need labs, an IV with fluids, an ultrasound, and perhaps IV pain medication, 2 or more resources. So she will be assigned ESI level 3 after the nurse looks at the patient's vital signs and notes they are within normal limits. If the patient's vital signs fell outside the accepted parameter for this age, in this case a heart rate greater than 100 or a respiratory rate greater than 20, she could up triage her to ESI level 2. If she was hypotensive or significantly tachycardic or had impaired mental status or was hemorrhaging that necessitated the need for immediate hemodynamic interventions, like fluid resuscitation or blood, she would meet criteria for ESI level 1. This is a good time to talk about the patient who presents with abdominal pain. Most patients with abdominal pain will be at least ESI level 3, consume many resources, labs, IV with fluids, IV medications, and a CAT scan. The elderly, patients in severe pain, or abnormal vital signs would meet ESI level 2 criteria. The need for hemodynamic interventions would make an abdominal pain ESI level 1, requiring immediate life-saving interventions. Okay, let's do a suicidal scenario. Okay, let's do a suicidal scenario. Okay, we have a 21-year-old female who comes in with her parents who said that her daughter expressed suicidal ideation after the boyfriend broke up with her. The patient denies being suicidal. She's alert, she's oriented times 3, she's a little bit non-cooperative. Her vitals are 97.9, 82, 20, and 115/70. She is requesting to leave. After all, she says she is 21 years old. So, with everything you know about this scenario, what triage level is she?
I know she's considered high risk and an ESI level 2, but I just don't get it. Why is she given such a high priority?
Well, that's a concern that many ED nurses have. So let's just go ahead and talk about it because we have a lot of these patients. This patient cannot be trusted. We must assume she's suicidal, therefore, she is high risk. If she were to leave and kill herself, you and the hospital would be liable.
You know, she may not get to your next bed, but this case really illustrates process and triage categorization subtleties. Some institutions will have a place for these patients. Others have protocols that require the triage nurse to immediately call for standby or for somebody to observe her and possibly notify a crisis worker or a psychiatric liaison.
And other institutions may draw labs for medical clearance. So we are actually doing quite a bit for these patients on arrival. But the bottom line is she is high risk and take credit for it. Don't sweat it. Suicidal, homicidal, and psychotic patients are very high risk. They only go a little. Okay, here's a new scenario. Here's a patient with a UTI. So the patient comes in and says, I think I have a UTI. It burns when I go to the bathroom, and I'm going all the time, and I only go a little bit. This is a 19-year-old patient who's had these symptoms for 24 hours. She denies abdominal pain, fever, chills, or any kind of vaginal discharge. She's healthy, no medications, no allergies. Her vital signs are good, 97.8, 80, 16, and 110/76. So, do we need a life-saving intervention here?
I don't think so.
Okay. How about high-risk criteria or severe pain or distress?
Not hardly. How about just a urine sample?
It sounds like a good plan. Does anybody think she's going to need anything else?
Well, it depends on which physician is working.
Yeah, I'm so glad you brought that up. You know, ESI is based only on the triage nurse's judgment of how many resources she thinks the patient will require to get the patient to a final disposition, whether that's home, admission, or transfer. This judgment is based on her experience and knowledge of emergency medicine, standards of care, and institutional protocols. Physician practice will vary, but ESI has shown that triage nurses do really well at predicting what patients will need.
And remember, the purpose of predicting resources is only to help assign a triage category to the lower acuity patients, the 3s, the 4s, the 5s. So if the story changes and the patient requires more resources, that's okay. You shouldn't triage differently based on how, who's working, how busy the department is. Okay, so let's go back to the case. Sounds like a urine is all we need. One resource, level 4 patient.
But wait, she's going to need a pregnancy test too.
Mm-hmm.
And we don't usually send our urines to the lab. We just dip it and then treat when necessary.
Well, let's talk about the pregnancy test first. Bedside testing, if that's what your institution does, doesn't count as a resource. Adding a pregnancy test doesn't change the number of resources. Lab counts as one resource, regardless of the number of tests you send or the type of specimen. For example, blood or urine or stool.
So this is another great example of some institutional differences that are handled without a problem using ESI. If the case you just discussed, if the urine is never sent to the lab, it is considered a bedside test, does not count as a resource, and the patient is a level 5. If at any point that urine goes to the lab, then we're back to ESI level 4, one resource. Okay, let's go back and watch some more video cases here.
I have an awful headache. I can't stand the pain. I've had headaches before, but not like this one.
You look really miserable. On a scale of 0 to 10, if 10 was the worst pain you could ever imagine, how would you rate it right now?
A 10 plus. I can't stand it.
Okay. When did this start?
Today, about an hour ago, I went to the bathroom. I moved my bowels, and it started right after that.
Okay. Are you having any nausea or vomiting?
I feel sick to my stomach. Can't you give me something for the pain?
No, not right now. You're going to see the doctor in a few minutes. So first I need to ask you a couple more questions and get your blood pressure, okay? How old are you?
35.
Okay. And do you have any medical problems?
No.
Do you take any medications every day for any reason?
No.
Okay. And do you have any allergies to medications?
No.
Okay.
This is an ESI level 2. This patient has a new onset, severe headache that is a typical presentation for a subarachnoid hemorrhage. This is a high-risk situation. Headaches are frequent complaints and are worthy of a little further discussion. Patients that present with their typical migraine headache are often triaged as ESI level 3. They usually require an IV with fluid and IV pain medication. However, migraine patients that know they only require an IM selective serotonin agonist and anti-migraine medicine will require only one resource, an IM medication, and therefore will be classified as ESI level 4. Even a patient with a typical migraine that presents in severe pain, vomiting at triage, even though it is a typical headache, could be triaged as ESI level 2 due to severe pain. To summarize, with headaches, history is important to rule out a high-risk situation. Then you really need to assess how the patient looks, and finally, how many resources you might anticipate will be needed. In this particular scenario, the patient met ESI level 2 criteria.
All right, so congratulations. We managed to clear out the waiting room and appropriately triage all our patients. Now, 30 minutes later, you're coming back from break. All of a sudden, MedCom calls. There is a mass casualty incident. A train pileup. A train crash that caused a 50-car pileup at 3 in the morning on Andrews Avenue, right near the hospital. Please activate your mass casualty. So these patients are already going to probably most likely be triaged before they even get to you. However, patients can roll in separately from EMS that are not triaged. So again, you're the person on the triage team when the rescues are rolling in with your 50-car pileup. Everything is on standby. You touch that patient, that's your patient. These patients are categorized differently than your emergency severity index. This is known as the START triage protocol. Some hospitals call this a code START, a code triage, a code green, internal disaster, external disaster, or a mass casualty. Now, we have 4 different types because you're going to be using a lot of resources on these patients. Their conditions are going to vary. You have your green, which is your minor. These are also known as your walking woundeds. Your delayed. These patients can wait. However, you must reassess your patients, as I stress. I can't stress that enough. I'm going to stress it again. These patient statuses can change, just like your ESI patients. Your red patients. These patients get red line. They're immediately to the trauma bay. And then black, no breathing, no pulse. Even after rescue breaths, after right positioning, they're still active, no pulse. They are black tag. They're deceased. They go straight to the morgue, depending on protocols. All right. So now we walk by. First thing we're going to do is, if you can hear me and you are able to walk, please come near me. Those are your green patients. Walking wounded. They're going to go to the green area, your minor area. These are your walking wounded. They can help control bleeding. You're going to be short-staffed. All hands are going to be on deck in this situation. It's important we reassess our patients. Your greens can become yellows. Your yellows can become reds. Your greens can become black tags. All right, now you have 1 patient. ANO times 4, just some bleeding there. You control the bleeding. They're not able to ambulate. They're delayed. They can wait a little bit. However, you must re-triage your patients. Now you have another patient. Open wounds. They're bleeding all over the place. They need to be seen right away. They're crashing. Textbook trauma patient. These are your immediate patients. These patients need to be seen and intervened immediately. And then, okay, got another patient coming in, rolled in, apneic, breathing, you reposition. Do maybe in the pediatric world, it's a kid, you do a couple rescue breaths. Nothing. Deceased. So you sorted all the patients, you managed to clear the disaster, you're done for the day. You think, okay, what liabilities do I have? How responsible is this triage nurse? Why do most experienced nurses go out to triage? Triage is a high-risk, high-liability situation. You are screening every single patient that walks in the door. Even sometimes you'll get a rescue out to triage. Patients' conditions can change. It is important that we are revitalizing your patients per policy. This even applies to your triage setting. You are to revitalize because you can always upgrade your triage. As I say, you can always upgrade, but you can never downgrade. Also in triage, EMTALA. This is known as the Emergency Medical Treatment and Active Labor Act. This was made out in 1986 as an anti-dumping law that patients need to be stabilized before transfer regardless of ability to pay. So if you have a patient coming in, I can't pay for this, I don't want to be seen, yada, 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 and they get turned away, it's an EMTALA violation. That's $40,000. I don't have $40,000. Do you? To pay this fine at someone's salary. That's why it's also important to also reassess your patients out in triage. I can't stress that enough because if they have an emergency medical condition, they need to be stabilized before their transfer, especially if your hospital doesn't have certain services. So the medical screening exam is not your triage assessment. This is to be done by a provider, a doctor, a PA, or an MD, or a DO, or a NP. Just so we're clear on that. The triage is not a medical screening exam. It just determines if a emergency medical condition is present, and that is up to the provider to determine based on your resources and examination. So I hope this is helpful with your triage. And please, if you have any questions, reach out. Enjoy, have fun triaging.